What is the abnormal displacement of bronchi, vessels, fissures, or septate called? On this axial CT, we see that the lung anatomy has a distorted appearance, and it's accompanied by volume loss. The answer is architectural distortion. Now, what the heck is architectural distortion? Well, architectural distortion is characterized by abnormal displacement of bronchi, vessels, fissures, or septate, and it's usually caused by diffuse or localized lung disease, particularly interstitial fibrosis. Lung anatomy has a distorted appearance and is usually associated with pulmonary fibrosis, as seen here, and accompanied by volume loss. There are many causes for architectural distortion. Here are a few cases of sarcoidosis. The chest X-ray on the left and coronal CT on the right show an individual with chronic sarcoidosis, showing upper lobe volume loss and upper lung zone predominant peribronchovascular fibrosis and architectural distortion, typical of end-stage disease. This chest X-ray of a different patient with end-stage sarcoidosis shows extensive architectural distortion with perihilar opacities, hilar retraction, and upper lobe volume loss, most pronounced on the right. This axial CT of a different patient with end-stage sarcoidosis shows marked architectural distortion in the left lung apex with near-complete replacement of the normal lung parenchyma by honeycomb cysts and associated traction bronchiectasis. Next is a case of tuberculosis. This chest X-ray in a patient with history of prior tuberculosis, TB, shows architectural distortion of the entire left lung with severe volume loss and intrinsic bronchiectasis. Note the shift of the mediastinum to the left. The next few cases are those of post-radiation changes. This axial CT of a patient treated for right upper lobe lung cancer with radiation shows marked right upper lobe volume loss with intrinsic vascular crowding and bronchiectasis. The resultant architectural distortion can be characterized as cicatricial atelectasis, which we'll discuss in future videos. Here's another case of post-radiation changes in this patient treated for mediastinal Hodgkin's lymphoma. There's a volume loss and bilateral paramediastinal architectural distortion with intrinsic traction bronchiectasis that conforms to the treatment port. Coronal CT of the same patient shows that left lung volume loss, bilateral paramediastinal architectural distortion with intrinsic air bronchograms and mediastinal calcifications due to treated lymphoma. This other case of post-radiation change in a different patient, which is post-radiation after breast cancer treatment, shows right upper lobe subpleural fibrosis with associated traction bronchiectasis and bronchiolectasis. Here is an axial CT of a patient with fibrotic NSIP, nonspecific interstitial pneumonia. There's bilateral lower lobe architectural distortion, which manifests as volume loss, reticular opacities, and traction bronchiectasis with bilateral posterior hilar retraction. This is another case of NSIP, though this one is associated with fibrotic drug-induced lung disease. This axial CT with amiodarone toxicity shows architectural distortion manifesting with basilar predominant subpleural reticulations with interlobular septal thickening and interlobular lines, but no honeycombing. The findings are consistent with an NSIP pattern of injury. Next case is one of complicated silicosis. This patient was a sandblaster, and this coronal CT shows profuse upper lobe predominant solid nodules and architectural distortion manifesting with upper lobe volume loss and intrinsic bronchiectasis. Our last case is one of COVID ARDS and the fibrotic sequelae of it. This axial CT of a patient who suffered from this shows asymmetric left greater than right architectural distortion, reticulation, and traction bronchiectasis, which is consistent with fibrosis as a sequelae of ARDS, acute respiratory distress syndrome. You now know a ton about architectural distortion. Please subscribe for more awesome anatomy and radiology videos.